It is my pleasure to welcome everyone to today's webinar, Building Support for Your Hospital at Home Program, Issues in Strategic Engagement. This webinar series is sponsored by the Hospital at Home Users Group with support from the John A. Hartford Foundation, the American Academy of Home Care Medicine, and the American Hospital Association. We'd like to extend a huge thanks to Gabrielle Schiller at Mount Sinai, as well as Noah Levine, Chris Gerst, and John Bielenson at Strategic Communications and Planning, who do the work behind the scenes to make these webinars possible. And now I'd like to introduce Dr. David Levine, who will moderate today's session. A member of the Hospital at Home Users Group leadership team, Dr. Levine is active in clinical and translational research through a focus on optimizing quality time at home by shifting care home, decentralizing care, digital health technology, and measuring the quality and experience of healthcare. He sees his role as helping patients achieve the right care at the right time in the right place by designing, implementing, and evaluating innovative interaction spaces between a care team, technology, and a patient. We're in good hands with Dr. Levine. Please take it away.
Thanks very much. Welcome, everyone. We're extremely excited to have everybody for one of our first Hospital Home Users Group webinars. Really excited to have so many people, especially with everything going on in hospital at home right now across the country. On behalf of all of us at the Users Group, particularly Al Su, Linda DeCherry, and Bruce Leff, really wanted to welcome everyone. We're extremely just anxious to hear what both Karen and Ryan have to start us off with today. Wanted to just briefly let everybody know that Hospital Home Users Group is essentially a users group that's open to everybody. And we are really a conglomeration of programs that are taking care of acutely ill adults at home. And so we have come together in order to essentially create practice standards, create quality measures, safety measures, talk about regulatory behind hospital at home, and want to join up with as many institutions and programs as there are, both in the United States as well as Canada. And extremely grateful to the John A. Hartford Foundation for their support of our users group and all the behind the scenes work that we've been doing to make this happen. So please feel free to sign up on our website, follow us on Twitter. You see our handle down there. And part of what we've been able to put together through the expertise of the users group is this series of webinars. So on the next slide, you'll see essentially some of the topics that we're going to be covering in the coming weeks in order to help potentially groups like you with your hospital at home program. And so on January 28th, we're going to be talking about patient selection, one of the most important parts of getting the right care to the right patient at the right place in the right time. We're then going to be talking about technology and how the electronic health record, as well as sensors and things like that, can support your work at home. We're going to be talking about operations. How do you get supply chain and staffing right for hospital at home programs? What kind of ancillary services do you need at home? How do you get that lunch served and still make sure it's hot when the patient gets it at home? And then look at quality, safety, as well as program evaluation, really important stuff. And so much more will be coming up on these, and we'll have kind of a complete schedule. But we're really excited to run through all these webinars with you all, as well as some office hours opportunities that we're going to be making available to folks in the near future, where you'll be able to sit with some of the country's experts in acute care at home and pick their brain about how to make this a better program for your patients at your institution. On the next slide, want to also discuss briefly essentially what we're going to be talking about today. So we wanted to start off with strategic engagement, because that is the most important thing that you need. You need your team, your C-suite, your clinicians, and your patients all bought in to the concept of acute care at home. It is something rather foreign that we haven't honestly really taught Americans, that it's the place to get care often is your home when you're really sick. And so in some ways, this is a large public health campaign that we are all on, and a public service announcement that we need to retrain Americans to think that when they are sick, they can actually get really high quality, safe care at home when they're very acutely ill. And so I'm really excited on the next slide to introduce our two speakers. The first is Karen Titchener. She is the Director of Strategic Development at Huntsman at Home and an adjunct assistant professor at the College of Nursing of the University of Utah. Karen has 22 years of experience developing and implementing not just one, not just two, but 5 hospital-at-home programs in both urban and rural settings for the NHS in the UK, and has been working in the US for the last 4 years for the Huntsman Cancer Institute, University of Utah, building an oncology hospital-at-home program. And as essentially an international expert on hospital-at-home, she has expertise in developing and operationalizing new programs with the emphasis on strategic and clinical engagement, developing clinical pathways, and working in an integrated and collaborative way. She had the largest program to date that she established in London, has over 85 staff and cares for approximately 3,000 patients in a year. She was awarded a Winston Churchill Fellowship in 2016, which she used to travel to Australia and New Zealand to study hospital home programs in these countries. And so truly is a world expert on this. We're extremely lucky to have her for this kickoff as well. And then very also excited to introduce Ryan Thompson, close colleague of mine. He is a general internist at Massachusetts General Hospital, where he's both active in outpatient and inpatient care and assistant professor of medicine at Harvard Medical School. He is the medical director of Care Continuum and Complex Care at MGH and the Mass General Physicians Organization. And in that role, he oversees care transitions and admission, readmission avoidance programs across the hospital, including none other than MGH's home hospital program. He also serves as the director of the Inpatient McGovern Service and Complex Care Service at the MGH Department of Medicine, and brings just a wealth of experience of also starting a program from the ground up and caring for hundreds of patients a year in the Boston area, with a great program running there as well. So with that, I'm gonna actually pass it off now to Karen on the next slide, and sit back and enjoy. The one piece I will just reiterate is, as you do have questions, because we have so many folks with us today, please put them in the Q&A box. I'll be taking a look at all those as we go in order to make sure we have a very lively Q&A once Karen and Ryan are done. Thanks so much.
Thank you very much, David, for that introduction. I'm very privileged to know and work with David for the last few years on Hospital at Home. Could you just go to the next slide, please? My background, as you heard, is in implementing hospital at home programs. So the program that I'm currently involved in is a hospital at home program purely for oncology patients. So it's a very niche market, but it is anybody who has active cancer and attend the Huntsman Cancer Institute is allowed to have this program. We service a 20-mile circumference area at the minute, but we know that patients who have cancer often have unplanned admissions and emergency department visits. And while most patients get their cancer treatment as outpatients, there are few models that really support patients in between their treatment and their clinic visits. So as a program, we are looking to provide that acute level care at home, adding value and trying to decrease unplanned admissions and emergency uses. The program has been running for just over 2.5 years, and it's a 3-year demonstration with 3 different separate bundles. Next slide, please. So the program really has 3 avenues because of the kind of patients that they look after. So we do have this acute care, which is a rapid response part of the program where we will see the patients within a few hours, and we'll either take that as a step down from the hospital or a step up from the community. This is one of the first hospital at home programs that we have allowed patients to self-refer once they have been on the program. I've never done that in any of my other programs, but again, because these patients are cancer patients, you know, if they're having chemotherapy and they've been on our program and they have nausea and vomiting at home, then it's far easier for them to just give us a quick call and say, hey, I've started my chemotherapy at home, please could you come and give me some fluids because I'm not able to keep anything down. And then, you know, obviously, again, because it's oncology patients, often they may transition to palliative care, but often they still get acute crises. So we keep them as part of the program. And then we also oversee the transition for patients to hospice care as well. Next slide, please. So the program is predominantly a nurse practitioner-led program, but we do obviously work very, very closely with the patient's own oncology physicians. And they are really, they have worked very, very closely with us, and they respond very quickly to any messages that we send them through about their patients. So currently the team has 9 nurse practitioners. We partner with a home health agency, and so we have 8 community RNs, and as I said, we serve a 20-mile radius. As we're part of an integrated system, our service helps a seamless transition of care between acute, palliative and hospice. The program does have 24/7 call, and we will respond within 2 hours of a patient requiring a visit. We also use, obviously, telehealth, telemedicine, and patient monitoring within this program. And one of our key aims is also to give family and care support, addressing, you know, the needs of feeling abandoned when they're sort of transition care from an acute setting to the home setting. Next slide, please. So, you know, why do we need a hospital at home? I think, you know, one of the key things that you have to do in order to tell your story is, why are you developing this program? So really, this is getting your story in order to communicate it to all these strategic people that you want to engage. So, you know, you need to look, what gaps is it that you're wanting to fill? So that's like scoping the need. What, you know, other areas that the patients fall through a gap, and they're not, you know, they lose touch with things. So what is it that you actually want? Which gap do you really want to fill? And then, where are the bigger pressures on the health system? We know that a lot of that is, you know, inpatient, but also the emergency room, where often they can get overwhelmed. You know, in the UK, this was set up all about demand management, because the hospitals are imploding, as they are just now with COVID, you know, on that demand, where, you know, the emergency rooms maybe have 500 to 700 patients going in every day, and they're just overwhelmed. So, you know, this program should be targeting what's your high demand, and therefore what is it that you want to target. And then, you know, kind of look at the low hanging fruit. What are the quick wins? Who are the easy patients that are the no-brainers that you can say, hey, we can take them straight away, because we know that we can look after them. They're not very complicated. And also, people who may be a bit wary of what kind of patient you're going to take, if you have quick successes, then they're more likely to get on board and engage with you. And then you have to consider, you know, what are your key performance indicators? What is it that you want the program to achieve? Is it that you want to, you know, improve bed capacity at the hospital? Is it that you want to reduce demand on the emergency room? So just think about the things that you want to, as part of your program, to be the performance indicator. And then, you know, what are you going to measure? What is it that you actually want to show people that your program can do? There are many sort of models of hospital at home programs there. I have done all of these, but, you know, you can have that rapid response aspect of your program. Your program can be purely admission avoidance, or it can be a mixture of early supported discharge and admission avoidance. Obviously, with the CMS waiver, it's all about the early discharge support, or the emergency room. Now, just as a demonstration, you know, we did a gap analysis so that we could see, well, what is it that we're looking to do? And in, you know, 2017, there was over 4,000 Huntsman patients went to the emergency room visits by 2,400 patients. So obviously some of those were rebounding patients. and 40% of those resulted in admission, and 35% were 30-day readmits with an average length of stay of 9.8 days. So you can see if you target you know, the readmissions and the emergency room, you're going to have a great benefit to your health system. Next slide, please. Thank you. Other things you might want to consider is, do you have a budget for the program? Not all of these programs will be fully self-funding, so you will have to have a pot of money that will help make the program sustainable. And then, what's your target audience? Again, you know, having done 5 programs, I have done over 18s, but I've also done sort of an over 65 model. So it really depends on, and I know with the CMS waiver, it will be over 65 that you're doing, but these are all kinds of things that you want to consider. In one of my London programs, for example, there was a high population of, you know, 50-year-olds with really bad COPD. So, you know, if you had an over 65, you would be excluding them. So it's just worth, again, thinking how you want to design your program. And then, what's your average length of stay? What's the team going to look like? What's your operation hours? Where are you going to sit? You know, are you going to sit in the hospital, or are you going to sit out in the community? And then, you know, your inclusion, exclusion, which will be discussed at a further one of these webinars. Next slide, please. Just a quick overview. In the first 18 months of our program, we did a trial, and these were the results. You know, we against usual care, where the cohort was 367. You know, we reduced unplanned hospital admissions by over 57%. We had a reduction in bed days and a reduction of 48% of emergency admissions, and a 47% reduction in charges. The only insignificant thing that we found was we didn't reduce ICU beds, but then we're hospital at home, not ICU at home. So we weren't really expecting to reduce ICU bed days. Next slide. So, you know, as David already said, strategic engagement is your key to success. It's the big key to success. So for me, you know, where the rubber hits the road, you know, have your plan. What is it that you want to do? Who do you want to talk to? What do you want to say? When are you going to do it? You know, define your audience, and then you present it depending on your audience. So, you know, all these people that I have put up here are all the people that you need to engage with, you know, and my experience would just say you can't present enough. You just have to, and even when your program's up and running, you know, you still need to go and talk to people. And, you know, in all of the programs that I've developed, we've always had a clinical engagement group. So the people that you want to buy into the program and to help you design the program, sit down around a table, say, hey, this is what we're thinking of doing. What do you think about this? And get their opinions, because I think if they feel that they have some part ownership in it, then they're more likely to, you know, to engage with it. I had one physician kind of say to me, oh, you're trying to teach us something that we've never learnt at medical school, and yet he was one of the early adopters, and he was a brilliant referrer to the program. So you can't present enough. You know, really going back to the original slides is, you know, what is it? What do you think that people want to hear? And then present that to them and say, look, we can help with this. What's the low-hanging fruit? All of those things you want to be able to present to these people. Next slide, please. And then, you know, meet with your key strategic stakeholders, not just before the program starts, but after the program has started. You know, continually iron out the glitches very, very early. You know, if there's lumps and bumps that need ironed out, please, you know, please can you sort those out early, because the quicker you sort out those things, the better it is for moving your program forward. As I already said, you know, involving clinicians in your design and your pathway development. Pathway development is a key to success as well. And my London program, I think we had like over 30 different clinical pathways for different patients, and that included mental health patients. So I think, you know, involving clinicians is key to moving your program forward with success. And scoping, and also, you know, when you're doing this, scoping the service gaps by getting out and about, going to the emergency room, going to the ward, spending time in the clinics and the community. You know, again, in all of my programs, I've gone to the emergency rooms. In my London program, when we developed a pathway with the London Ambulance Service, I stood outside the emergency rooms, and every ambulance that came in, you know, I said, hey, we could have taken this patient, and, you know, printed out our pathway and things like that. So, you know, physical presence and presenting your program and working alongside people and wooing them along and helping them to understand the complexities of the program is really, really important to the success. So, you know, building confidence in the program by promoting it, by and getting it understood. Next slide, please. So also, you know, how do you build confidence in the program? Spread the good news. So, you know, patient stories are always one of the great ways of spreading the good news. You know, when we started very, very early on, when the patients went into clinic, they would tell their oncologists, you know, about the nurse practitioners and the RNs who had been to their home. And the more that the patients did that, the more referrals we got, because, you know, the patients are the best good news spreaders that you could possibly have. And also, as I said earlier on, you know, iron out the blips and hiccups very, very early on, address them and address people's concerns. If something does go wrong, you know, sit down, work out what went wrong, you know, engage the oncologist, engage the patients, and make sure that that you learn by your mistakes and you're able to move forward. And staff engagement, I can't emphasize that enough. As I said, you know, I've presented to clinics, I've spent time in clinics, so we've put posters up, you know, we put zip code posters up, you know, anything that will help engage people. And then obviously we have leaflets for staff and patients to try and get everybody engaged. Next slide, please. So I just quickly want to, I'll just fly through these because I'm sure my time's running out. But enablers to your success, for me, one of the big enablers is that you've got the right leadership, that you've got dedicated people who are developing and operationalizing the program, and that you've got an effective business support behind that, that your funding's recurrent and stable, that you have regular meetings with stakeholders. You know, is your model scalable? If you've started it quite small, is that model going to be workable if you decide to expand? As I mentioned before, having clear patient pathways and referral processes is key to success. I've always found that having one number is great for people. So a single point access where everybody, if somebody's on the program or somebody is interested in the program, they've just got one number. You know, our program at the minute has one number for providers and for patients, and they all call into that number. Obviously, it is a routing system that, you know, 7 or 8 calls can come in at once. Again, I've emphasized before, you know, the physical presence is really, really important. You know, showing your face in the emergency room, on the medical wards, on the discharge planning meetings, In my London program, we had case finders. We actually had nurse practitioners sitting in the emergency rooms pulling patients, but that was a big program. So, you know, we were getting 25 referrals a day, but it was well worth having those nurse practitioners in the emergency room to pull those patients. Next slide, please. You know, having excellent clinical care with best practice, good training system, integrated multidisciplinary team working, consistency of the service presence, as I said, in the acute hospitals. Something that we've had in several of our programs is that our clinical staff carry first dose kit so that there's no delay in treatment, you know, apart from opioids in America, which we don't carry, but you know, your IV antibiotics, IV nausea medication, IV fluids, you know, that so that there's no delay in treatment, and then you can prescribe after that. But we find that really, really helpful. And having a ready-made store so that, you know, you can bring out a walking frame or something, you know, there and then when the patient needs it, and that will help you to succeed. I think that's my time, and I think I'm done. Thank you. David, back to you, or oh, sorry, Ryan, or it's up to you.
Yeah, well, thank you so much, Karen. We will we'll go right to Ryan. Ryan, really excited for your talk.
Great, thank you. I'm really glad to be here. Thanks to the users group, David and others for organizing this. I think it's wonderful to be coming together with people all around the country to be talking about this really important and exciting topic of hospital at home. So I'm coming at you from Boston. I work within the Mass General Hospital and our program, which has been in place for about 4 years now. We were fortunate to have a forward-thinking leader that put this in place, and are glad to share with you, I think, what we've learned here in the form of sort of a starter kit theme. Some similar themes to Karen. I think if you were to hear from any of the home hospital programs in existence, you would hear a lot of the same themes about how we all got started, which is why we're sharing this. So next slide. I'll sort of get through this. I mean, this is some of the conceptual stuff. You know, I think everybody knows. I mean, I did one home visit before I started working in this program when I was an intern back in 2005. It's just not something that we do. And I've sort of put this slide in here because when we started this program and I started seeing patients at home for the first time in years, I was struck by how people anchor on this concept of house calls. That's just a term that's sort of known, that's maybe an old school term. But, you know, in thinking of that term in this day and age, we're actually leveraging this so-called old school model to solve modern day problems, which is high cost, hospital capacity, and sort of, I think the newest one that's come up during this COVID era is patients are frightened to come into the hospital. And so we need to take the hospital to them. We now have tools and technologies. If you go to the next slide, you just sort of outline some of these. You know, this work is really fun, actually. You can click ahead just to pull up the animation. Sorry about that. A couple more clicks. One more. I mean, this is sort of, back one, sorry. This is sort of how we think about this. You know, there are new partnerships, there are new technologies. We're looking to leverage site of care to be more efficient. And ultimately, we're doing this in a patient-centered way that in this current era right now, keep patients at home where they want to be. The little quote at the bottom is kind of a funny one, but it's one that came up in one of our early patients. He is in the Back Bay in Boston, if you've ever been to Boston. And I asked him how his home hospitalization was working for him. And our hospital is at capacity all the time. And he waited in the ED for about 12 hours for a bed. And he said, well, doc, at the end of the day, you guys didn't have a bed for me, but I did. And that's sort of a light bulb went off there. That really is what this is all about here. There are plenty of beds in patients' homes. We just have to come up with safe ways to take care of them. And that's what this care model is all about. Next slide. So I don't really go into detail on our Mass General program design. Happy to share that with any of you offline if you're interested. I think you're going to find similar themes across any of these programs. What I'm going to walk through is a couple slides around what I call a starter kit. So what do you need to have in place if you want to get this going? And again, similar themes as what Karen shared from their amazing program out in Salt Lake City. I'll sort of walk through how we've thought about this here. Number one, and Karen mentioned this, and I think this is really, really critical. You have to have the vision right at the top. David mentioned the C-suite earlier. There's got to be a commitment and sponsorship. In our institutions, this was Tim Ferriss, who's now the CEO of our physicians group. He ran population health for our healthcare system and really had the foresight and the wisdom to invest in this and made the financial commitment. It does take that. This Medicare waiver that's new is opened up all sorts of possibilities to actually do this in a financially viable way, but it does take some upfront commitment to get the infrastructure in place to begin billing. It's not something you want to do on a whim. I think it's also important, and Karen also spoke about this, that any institution has clarified what its aim is or its burning platform. For us here in Boston, it's our hospital and capacity needs in the ED. That's a crisis on a daily basis. We are also in many risk contracts with Medicare, with several private payers, and so reducing total medical expense is an equally important secondary priority that's right up there. I think nowadays, the way that the market is going, patients are starting to actually want this. There's going to be some competitors of yours, perhaps, depending on your marketplace, that are going to start doing this, whether it's an insurer that's doing this or another system. And so patients are sort of, they might demand this. I think more than likely it's going to be a mix of the above, which it is for us, but having that clarified, why are you doing this is really important. The leadership of taking this on is important. So I sort of use the term here, an innovative and adventurous clinical leader. It's important to have the right person taking this on for your institution. It's got to be somebody with credibility who can sort of sell this model to peers at your institution. There's going to be some early adopters. Karen talked about that. There's going to be some laggards. Having somebody who can sort of pitch this in the right way, explain it to their peers, make them feel like it's safe care is really important. This person needs the time to lead the program. I think especially, for institutions who have to have these initial cases, would highly recommend this clinical leader being directly involved in those cases so that he or she has credibility, has experience, and can sort of share that experience in the form of stories and anecdotes with peers. And then obviously having an effective administrator, which we have in our program, is absolutely crucial to make this work. There's a lot of nuts and bolts, a lot of administrative coordination, and you really need a crackerjack person who's got some time to make this work. Next slide. This is a slide just, in terms of sort of defining opportunities. So this is an example of an analysis we did at MGH, fairly straightforward. We looked at the conditions, that Medicare has a term, ambulatory care sensitive conditions, pretty straightforward. Cellulitis, pneumonia, heart failure, COPD, urinary tract infection, just a basic set of conditions. How many admissions to the medical service did we have? In a geography, this is about a 20-mile radius around Mass General, and excluding, of course, ICU admissions. And we sort of defined this opportunity within a calendar year. We know we're never going to get all of these patients, but even if we were to get, 20% of these or 25% of these, that would be, 250 to 300 patients over the course of a year. And that would really help our hospital, assuming that each of these would be admitted for, 4, 5, or 6 days to the hospital for their treatment. And so this is just something that you want to do to define. You can do this in different ways, different geographies, different conditions, but it's an example of what you want to do to define your opportunity. Next slide. A lot of partnerships to do this. This is a list of some that are really crucial for this. I really think that CMS has done an excellent job in designing the waiver in consultation with our users group leadership here. Home care, home infusion, technology, diagnostics, all these different partnerships. It may seem overwhelming to sort of, how do I bring all that together? Most of these partnerships already exist within your hospital. So you can either build on those. Hospitals will have a respiratory group, right? They have a pharmacy. Whether you can leverage those or whether you need to leverage a community-based partnership, if you don't have the right DME set up for this in your institution, there's going to be a local home care agency that will have a lot of community-based partnerships. And what it might take is actually a contractual arrangement or some shared arrangement with the home care agency to sort of pull a lot of this together. You bring the expertise of the acute care hospital for the acute care of the patients, and then there's community partners who bring their aspects to the table, and it's really a joint venture. That's how our program is designed. We happen to be fortunate to have a home care agency within our system. So it was a very easy partnership for us to form. We know not everybody has that, but I think partnerships are critical to this, and I would anticipate that there would be some eager partners out there with you that can work on this. Next slide. So this is an example of the set of stakeholders. And again, this might seem overwhelming here, but you know, generally people think this is really cool. Everybody I've never had anybody give me a funny look as I've talked around the hospital about this program, saying, what do you guys think you're doing? This model makes sense to people, and everybody that we've worked with has really been excited to participate. So again, not wanting to run down all the lists here, you'll have these slides, but you know, there are stakeholders that need to come together, and there are some things to figure out here. Again, CMS has laid out the template in the waiver application of all the things you need, and that's where the leadership comes in, is to sort of convene with the support of the executive sponsor, the clinical and administrative leaders, you know, sort of work through cases and how you're going to do this. You have to find patients, you have to coordinate care while on service, you've got to discharge them, etc. So again, we offer this as just sort of a template for, you know, who you might need to bring together to make sure that you're doing this in the right way, with the focus always on safe care. Next slide. I think I have just a couple left here. So these are just some final kind of startup tips on this. Obviously, we've spoken about inclusion and exclusion criteria, defining the right patients. That's really important. We've done that work. You may have variations on it, but the users group, our hospitals who participated, are glad to share. Dr. Levine has published studies with his criteria, plenty out there. You don't have to reinvent the wheel. We very much have a learn by doing mentality, what we call let's try one in our program. We are constantly reviewing cases. We did it just today with some cases from the weekend. What did we learn? What did we do better? What could we do better? What went well? And I think if you have that mindset, you really sort of push the envelope and can advance this work by trying things out and then having processes to sort of debrief and continually improve. Karen picked up on this theme of what I call academic detailing. So going around, getting clinicians to buy in. It's sort of like, you know, if you've done any lobbying before. I haven't done much, but I was always told when I did a little bit of that in medical school that, you know, that politicians respond to stories. You can show all the charts you want, and data is important, especially in hospitals, but patient stories around successful cases really goes a long way. I call it the light bulb phenomenon. You sort of share a story with a primary care physician or a specialist about a case that went well, and a light bulb goes off because they're going to have one of those patients too. We also like to call out successful referrals. If we had a great case that was pushed to us by an emergency clinician, we like to sort of respond and call that out to them. I think it's really important at the get-go to consider health equity in doing this, whatever your setup is, especially around patient selection. There is technology here, and I think it's crucially important for all of us to be mindful of that as we set these programs up. Next slide. Okay, so I'm going to have you click through. I have I guess, and I didn't realize it was an animation at the bottom. Sorry. I got 2 more slides here. So one of the challenges with it, and I did see a question that I'm sure David will get to around, yeah, you can stop there, around, we have what we call the needle in a haystack problem. It is actually hard to find some of these patients. There's a little bit of a narrow sort of corridor here. You know, there's limits around geography, clinical appropriateness, time of day, et cetera. And so as you build this, you know, you're going to start with a basics. You're going to start with basic conditions during the day within a 5 to 7 or 10 mile geography. But as you go, you can expand this. If you're going to invest in this, you want to actually get to scale and actually get to volume. And so having a strategy where you can expand all of these circles, where you can expand your appropriateness. Karen mentioned she has 30 different conditions, pathways, or protocols in her program. I know our counterparts at Brigham and Women's have a lot of protocols that they employ. We've got several as well. You can expand it to the evening, which we're in the process of doing now at Mass General. You can expand your geography, especially leveraging technology and community collaborations. And then you also need to get more and more people to buy into this. I think that it's much easier to get people to do this program since COVID, because nobody wants to come into the hospital, and folks are generally welcome. They welcome the chance to be home. And so these are just some things to keep in mind as you start up your program. Next slide. This just shows you where we're going. I mean, we of course started off with general medicine here, but we have an oncology pilot going. We also are doing a pilot that we're just about finished with, our first 10 patients of post-op recovery. Our governor asked us to reduce elective surgeries. We've been able to keep some surgeries going by having them recover in a hotel with our home hospital team taking care of them in the post-op setting. And we've had wonderful feedback on that. We're working on sickle cell disease, a really challenging condition, trying to treat some of those patients at home. You can see some of the other conditions here. You know, we're really not into pediatrics yet. We get asked about it. We do have a children's hospital. I'd love to see the day when we could do that. It's not part of a current plan, but it's something in the future that we should be able to do. Next slide. That might be my last one. Maybe one more. Okay, yeah, this is my last one. I was asked to put in a slide just around our experience thus far with the Medicare waiver, the acute hospital care at home waiver. And the short answer is it's been fantastic. And I say that because CMS has worked really hard to make this as easy as possible for hospitals to launch. It's not easy in that to do this well and to meet safety standards and expectations for appropriate care is actually, you have to know what you're doing, and you have to invest in the resources and structures. But I think CMS is doing its very best to enable hospitals to do this. They've been very responsive to any questions we've sent them. Our couple of bullets of advice on this are around, there are conditions of participation for Medicare. Your compliance department runs those. It's important to crosswalk those with the hospital at home. That was a very useful exercise for us to do. We already had EHR is a topic in and of itself, probably covered in a later webinar. We had an encounter that was inpatient-like, built for our programs that we've been able to leverage. That was fortunate for us. But really, billing is sort of the same as an inpatient charge. That's how CMS has set it up. You just have to add a condition code for Hospital Without Walls. We've benefited from the waiver to sort of evolve all of our processes to match that workflow. We're trying to not have separate workflows for Medicare versus others, which I think has been helpful for us to streamline. Similar to the Huntsman program in Utah, we have admitted patients directly from home or clinic where it was sort of a safe bet that they were headed into the hospital. They needed clear IV diuresis for several days or IV antibiotics. This is not covered under the CMS waiver for, I think for good reason to start. However, we are going to still do these because we feel like it's the right pathway for some patients. This has been a challenge for us because it's caused us to have to tweak our operations. We're focusing more on drawing transfers out of the hospital early in the home hospital. So that's been an operational change for us. Other than that, though, it's been fantastic. We're very grateful to have it and appreciate the vision of CMS in doing this, and of the users group in supporting current and also new partners among hospitals in doing this. So I think that's it for me, and I'm going to kick it back to the central team for Q&A and whatever's next.
Excellent. Thanks so much, Ryan. Thanks so much, Karen. Really great presentations. We have dozens and dozens of questions for you both. We will not get to them all, but get ready. Some of them will be rapid fire, and others I think will be a great discussion. I think want to start off with a general theme from a lot of the questions I'm seeing, which is kind of how big are you and how big can you get and how fast can you do that? Karen is very well known in the World Hospital at Home Congress for giving a great keynote on go big or go home in home hospital, the home hospital world. And so, you know, if you could, when you kind of respond to kind of that, people have asked, what's your average ADC, average daily census? People have asked, how many FTE do you need to support that ADC? And people have even asked if you'd be comfortable talking about your budget, a ballpark budget for what it takes to make that ADC happen. Would be great if both, maybe Karen first and then Ryan could follow that up.
Sure. Yeah. Yeah. You've got me sus, David. I always say go big or go broke, simply because for me in any program, you know, if you're doing tiny amounts of patients, your impact, it's going to be hard to buy people in. But of course, you have to start where you feel is safe and where you're ready for. The program, the Huntsman at Home program, has a daily census of around 67 patients. And we have, as I said, 9 full-time equivalents, nurse practitioners, and 8 RNs. And then we have the backup of the medical teams as well. Our budget, because we were a demonstration program and we had philanthropy, we had around 2 million a year for 3 years to do our program. But we are learning, and obviously with the CMS waiver now, we're learning how to get more things reimbursable. You know, we just wanted to get up and running. We didn't want to discriminate against people who had no funding compared to people who had full funding. So we give patients care whether they had you know, a payer or not, because that's what we wanted to do. We wanted to do equity of care. So I don't know if that's helpful.
Yeah, I'll give I guess, an unfortunate contrast in that we're smaller, though we are growing. And so our program is supported by our system via a population health investment. Bootstrapped costs. There's been no ability to bill for this, and so it's been a central investment to basically build a model because we felt it's the right thing to do. We're fortunate to have had, you know, David within our system, whose team did research to prove that this model is not only safe but cost effective, which is sort of a no-brainer. Hospital care at home is going to be cheaper than care in the hospital. He just proved that with a randomized control trial. That's made this story much easier to tell. And so our sister hospital, Brigham and Women's, sort of self-funded to expand, you know, 1.5 or 2 years ago. Our hospital is doing that more recently, but we're really growing. We only have 3 full-time APPs now and 3 full-time nurses. We have a sort of a lighter touch physician model. Our program is mostly nurse practitioners and PAs. And so we only take care of maybe 4 or 5 patients at a time as our census cap. But we're planning to increase that in a phase way over the next couple of months, up to 8 and then 12 and then eventually 16. The key is to fill that. And again, patient selection's hard here. It's been hard for us to find patients out of the ED. Patients drive from pretty far away to come to our academic hospital. But we think with the move to inpatients and early transfers home, we're going to have no problem filling our census as we grow. I will say it can be hard to hire in this space. However, and you know, I think it depends on your marketplace. We're in a very saturated marketplace for healthcare. I think there are some hesitations with clinicians wanting to work in the home. The clinicians we have are fantastic. We're grateful for them, and I think with the right strategy, we will have no problem eventually getting to where we want to be. We do feel like we need to really make a dent both in capacity and in total medical expense. We need to get up to that 12 to 16 patient census to make a difference.
Great, thanks to you both. You know, another kind of theme through the questions here is whether you all have a recommendation for programs that are just starting out as to which model to start with, right? Is it from the ED? Is it from the home? Is it from the floor? Is it a combination? Karen and Ryan, what are your thoughts on
that? I think, you know, the low-hanging fruit is trying to shave bed days. So especially for a program that's just starting, because one, that patient will have been evaluated and assessed, you know, quite significantly compared to a patient who might hit the emergency room or be a step up from the community. So I think CMS waiver, is a great place to start. So, getting those patients out as quickly as possible, and then the emergency room. And once you're up and running, I'm not sure whether we'll ever get funded taking them from home in this country, but it works very, very well. Patients taking them from the community, even if we could take them from the ambulance service, that would be amazing. But I think we are where we are, so I think inpatient and emergency room is a great place to start. And then look at your diseases. Is it your congestive cardiac failure? Is it your COPD? Just look at low-hanging fruit patients that are good to start with.
Yeah, I would basically double down on what Karen's saying, maybe with one small tweak. I think it does sort of depend on your core aim. If your focus is on total medical expense reduction, and you're going to do this in an at-risk population, certainly trying to avoid admission altogether is smart. And so there's your ED population, and you might actually want to think about admission avoidance at home, knowing that Medicare is not going to pay for that to support your costs. But if you can get that right, you could avoid admission altogether. It's challenging. The challenge with the ED is it's chaotic. You don't know when your volume is going to come. You don't have you might have a day where, and all of our hospitals have had this, where you have teams that are scouring the ED board for patients and they don't find anybody that's a fit. That happens to us. For the inpatients, to sort of double down on Karen's point, you have a captive audience there. You sort of have those patients, they've stabilized, you sort of know what you're dealing with. And so I do think the lowest hanging fruit is to get patients out for early transfer. I think the Medicare playbook here probably defines the strategy most hospitals would want to follow, which is to focus on ED and early inpatient transfers. I think with the latter being the one that might be the easiest place to start, because I think the finding is a little bit easier. You won't save the cost there though, because the DRG payment is going to be sort of paid at the inpatient level.
Great, thanks to you both. Ryan, a quick question for you that came out of that slide you showed on your exercise, looking at kind of the admissions in a geographic space. Just a quick nuts and bolts question, but I think it's really important for folks who are starting out. When you did your analysis of common conditions, did you include not just admissions, but also OBS, or did you only look at inpatient?
Yeah, so that's a great question. That was just inpatient. I think you can do that analysis in other ways. You could include OBS. We did not. We were looking to be with hospital at home substituted for an inpatient stay. And so we only analyzed inpatients there. I think if a program wanted to also take on OBS you can alleviate some bed days there, you could broaden the analysis to include that. That just wasn't our focus.
Great. And wonder if both of you would share about how you all do consenting of patients being cared for, especially given different conditions of participation, and kind of what does that process look like for your programs?
And for us, that's done on the first visit. It's part of the health system records anyway, that they consent to care. So it's pretty easy, really.
Yeah, we have a pretty elaborate consent form that our coordinator kind of patient finder reviews, and it's sort of, reviewed finally and signed off on with our admitting clinician. And so it's really handled and signed by the patient at the outset of the admission. Great.
Another question has come up from your perspective. We've been talking a lot about CMS here. And the waiver, and obviously it's a big deal for all of our programs across the country, and they're really taking a leadership role there. Wonder your thoughts on commercial payers. What is the role of commercial payers? What sort of best practices should they be looking at if they were to work with a home hospital program, say in Salt Lake or in Boston?
Yeah, I mean, I think your evidence is what you have to get, which is why we continue to evaluate between the patients that are in our program and the patients that would match our program but aren't in the area. So we try and sort of do the propensity weighted scores when we're doing that. But I think you have to present evidence to say, look, these are the patients that we've seen. You know, they had 10 hospital admissions in the preceding 6 months. They haven't had any since we've been looking after them. You know, getting evidence. I mean, I think, you know, this has got to be the way forward. For me, it's a no-brainer. You know, it's great that Medicare has got on board, and I think it'll wake up other payers to say, we've got to do this, because we've, you know, hospital at home, as Ryan has already said, you know, is the way forward. The rest of the world has been doing it for many, many years. And I think payers, I think they will start looking at it and think, you know, maybe give you a per member per month or something, that we can look after these patients. But I definitely think they've got to wake up and do it.
And I would just add, I mean, I would recommend, if you're going to take the plunge and do this, you know, it's the right thing to do for patients. Patients really benefit from it and appreciate it. And so I think, as David mentioned, Medicare is leading the way here. Private payers, as we know, tend to follow Medicare on this stuff. And so I think it's actually a great time to work with your, you know, contract relations, payer relations folks, and have these conversations. You know, our system is in a contract with a forward-thinking private payer that's gone well, and we've learned a lot, and we've talked with them. They care about their patients, and they want them to be served well. We have a program that can serve their patients, and so we've sort of come up with mutually beneficial ways to move forward with this. I think now this Medicare decision to offer this waiver to interested hospitals will only accelerate this. And I think they've also shown, you know, the template for how this ought to be designed. And I think, you know, Administrator Verma has also sent a letter to every state, every governor in all 50 states, encouraging their Medicaid divisions to implement this as well, which hopefully several states are doing. So hopefully this will spread. The ultimate, you know, way to scale this is to have all payers pay for this, which will take some time to get there, but we're moving in that direction.
Yep, great comments. Last question, and apologies to the dozens of questions we haven't gotten to. A lot of them are actually about upcoming webinars, so we're going to keep them for upcoming webinars. But the last question I wanted to end on is if you could both kind of comment on how health equity and a health equity lens has kind of shaped your program, and what kind of considerations folks might take for building their own.
Well, I'll start there. I mean, health equity is a core part of our mission. We don't select patients based on, I guess, equity considerations, but it's part of everything we think about. And we have to make sure that anything we implement, especially when it comes to technology, is available and is workable for everybody. We've just implemented a virtual observation unit program specifically focused on COVID, not hospital at home per se, but sort of related to it, around some monitoring and follow-up using paramedics in the home for COVID positive patients, and are very careful in the very core of the design there, especially with who our COVID population and MGH has tended to be a lot of patients who are Spanish speaking and Portuguese speaking, that we have a setup for them so that they really get equal care, even if the fancy technology may not be something they can use. And so I would say it's a mission concern. And it's, you know, and there's also some equity considerations around age as well. There's some very elderly patients who just aren't able to use technology. We have to make sure we have equal offerings to them that don't stint their care. And I think we have that as a core part of the mission.
Yeah, I agree with everything that Ryan has said, really. Again, we don't choose our patients depending on whether they've got funding or not. It's based on need and based on, you know, how we can help them. So we try and be as equitable as possible, including even if people's first language isn't, you know, it isn't English. We have interpretation iPads that we bring out so that we can still, there was one patient we had that was in a tribe in Africa somewhere, and we couldn't get an interpreter for him, so we had to wait for his daughter to come. But apart from that, you know, we haven't denied people care because their English isn't their first language. So I think it's really, really important that everybody gets cared for within these programs.
Well, great. Well, thanks everybody very much. Special thanks to Karen and Ryan for your great talks. Thank you all very much. Really importantly, all of this material, the recording, the slides, contact information for the speakers is all available on the users group website. I know it's been posted in the chat a few times. Special thanks again to the John A. Hartford Foundation, as well as the AHA and HHCM for sponsoring this. And there's a really exciting and organic and forming toolkit for starting your hospital at home program that it is on the website that you see right there. We also are going to be holding more webinars, so don't go away. We're probably going to be holding one a week because we know how fast people are setting these programs up and need help. And so every week we're going to be tackling another topic that you saw originally listed. We're also going to be holding office hours with experts like Ryan and Karen, who will be literally just hanging out, ready to answer some of your questions in a more intimate environment. And then finally, just a quick reminder, you will receive a quick survey as soon as you close this. If you wouldn't mind just giving us quick feedback on whether or not this is helpful and what you're looking for. Again, the users group is putting a ton of effort into making this helpful for programs all across the country. And we really want folks for this to be high yield and high value for you all. And so hope to see you on January 28th, our next one, which is going to talk about all the details and nuts and bolts of inclusion and exclusion criteria, who's in, who's out. We'll be really excited to see you then. And until then, have a great rest of the week. And everyone, please be safe and take care.